A 32-year-old woman comes to the physician with severe colicky, flank pain, and recurring cough. Physical examination is significant for left-sided costovertebral angle tenderness and multiple red nodules on the patient's lower legs. A urinalysis shows envelope-shaped crystals. Which of the following is most likely to also be found in this patient? Choice A, Proteus mirabilis infection. Choice B, increased gastrin secretion. Choice C, keratin pearls on lung biopsy. Choice D, decreased stool cation concentration. Or choice E, self-mutilating behavior. I'll wait 5 seconds and answer the question. So obviously we have a nephrolithiasis here, kidney stones. We have envelope-shaped crystals, which means they're calcium oxalate crystals. That means this patient probably has some kind of problem with calcium, and this in combination with the erythema nodosum on his lower legs makes sarcoidosis the most likely diagnosis. So choice D, decreased stool cation concentration, is the correct answer. Now, of course, with sarcoidosis, you usually think like African-American woman in her 30s, bilateral hilar adenopathy. A lot of questions do give you the hilar adenopathy. I just decided to not give it to you here because I wanted to make a harder question. And quick review for those of you who are not in the loop. Of course, in sarcoidosis, you have granulomas being formed, and the activated macrophages have very high 1-alpha hydroxylase activity, which of course you should know as part of your vitamin D metabolism. So vitamin D after 1-alpha hydroxylase gets activated into 1,25 dihydroxy vitamin D, which is the activated form of vitamin D. So in sarcoidosis, you often have a hypervitaminosis D, which causes various effects, including absorbing more calcium from the intestines and various other things to increase calcium in the blood. So you have hypercalcemia. And since you're absorbing more calcium from the intestines, then you would have decreased cation concentration or calcium ions in the stool. Like I said, typical sarcoidosis question would probably be easier than this because I was deliberately vague. But let's look at the other answer choices here because you can eliminate them and they're all things you should know. Choice A, Proteus mirabilis infection. You of course want to know that this is a urease positive organism. So since it has urease, it converts urea to ammonia in the kidneys, which alkalinizes the urine. So that can cause magnesium ammonium phosphate, aka struvite stones, to form. If you looked at struvite crystals under the microscope, they would have coffin lid appearance and not envelope-shaped crystals. And aside from that, this patient really doesn't have anything to indicate that she has some kind of infection, so it's not the best answer choice here. Choice B, increased gastrin secretion. Now, in both MEN1 and MEN2A, you can have parathyroid hyperplasia, which can lead to hypercalcemia. So for this particular answer choice, if you're thinking MEN1, which would be pituitary adenoma, parathyroid hyperplasia, and pancreatic tumors, and that can be a number of tumors, including a gastrinoma secreting gastrin, which would cause Zollinger-Ellison syndrome. You can have MEN type 1 and MEN type 2A in the back of your mind when you see a patient with hypercalcemia, but you really want other clues to be pointing you towards them, and erythema nodosum is also not really found in these. Choice C, keratin pearls on lung biopsy. This is referring to squamous cell carcinoma of the lung. Keratin pearls are of course found in squamous cell carcinomas of basically any type. But what you want to know about squamous cell carcinoma of the lung in particular is that it can secrete PTHrP, which has the same function as PTH essentially, and so of course that can also result in hypercalcemia. But again, squamous cell carcinoma of the lung, you usually don't think of erythema nodosum. Choice E, self-mutilating behavior. As far as USMLE goes, I think the only condition that really has this as a symptom is Lesch-Nyhan syndrome. It's a diagnosis that comes up a decent amount of times on MBMEs. This is one of the X-linked recessive diseases that you want to know about. It's caused by an HGPRT, or hypoxanthine guanine phosphoribosyl pyrophosphate transferase deficiency, which is a huge mouthful. It's unlikely they're going to require that you know what it stands for, so just know HGPRT. So without HGPRT to salvage your purines, you'll have a bunch of hypoxanthine and guanine floating around, and they'll be instead converting to a bunch of uric acid. So patients with Lesch-Nyhan syndrome would have pretty severe hyperuricemia and therefore gout. You get intellectual disability, and self-mutilating behavior is like the buzzy symptom that you hear about. And of course, since we're on the subject, obviously like this is a congenital issue and you would usually find it presenting in children. This patient being a 30s woman is one of the reasons you would be suspecting sarcoidosis in the first place, right? So bring it back. This is pretty much just a combination of a nephrolithiasis question with a sarcoidosis question. Obviously, I didn't give you the obvious symptoms this time, but pretty much all the answer choices here are fairly high yield, so you should have been able to recognize all of them. Hope you found this video helpful. I'll see you in the next one.